Good evening and welcome to the Roselle Center for Healing's ongoing webinar series. I will be your host, Dr. Harlan Browning, and tonight's topic will cover low back and spinal pain. We will review several different things, including the different types of pains and impairments. We'll look at basic spinal anatomy and biomechanics. We'll talk about something referred to as the vertebral subluxation complex. We'll look closer at the importance of posture and body mechanics. I'll go through 6 of the most common causes of low back pain and sciatica. I'm going to touch on what I refer to as the importance of the patient encounter. And lastly, probably the most important, we're going to talk about treating the problem as opposed to just treating the symptom of the problem. Well, no webinar will be complete without having some form of statistics. So I put these in here for you to understand the significance and the commonality of low back pain across all different age categories. The National Institutes of Health states that 80% of all people experience back pain sometime during their life. It's actually the second most common reason for a visit to any healthcare provider, behind only respiratory infections, the common cold, flu, and things of that nature. It's one of the most common causes of missed work time, and upwards of 50% of all working Americans admit to having low back pain each year. As a cost, it can total more than $50 billion a year to treat, to diagnose, and unfortunately not fix. If you've ever seen my presentations before on any type of pain, you'll understand these next 2 slides because I put them in there often. And I think many people don't understand the difference between the different types of pain. The first one we're going to talk about is acute pain. It usually lasts less than 2 months of duration, and it consists of more of a sharp, burning, stabbing, or localized pain that is usually quite intense. Conversely, chronic pain usually lasts more than 2 months of duration and typically feels more sore, achy, generalized, and the intensity is most commonly dull. The unfortunate thing is when a person transitions from the acute to chronic stage, we often see the nervous system not understand how to deal with this. And this is when people will often get caught up on treating the symptom and not correcting the problem. Well, let's talk about what I refer to as pain versus impairment. And really what you're going to look at is the subjective nature. That's what the person perceives. That's their pain and all the associated things that they feel, versus what is objective. Those are the things that the doctor can measure, and certainly certain things that the person can notice as themselves as far as losing function. Subjectively, or what the patient perceives, has a lot to do with the level of pain, the quality of pain, and all of the associated things that might be happening. Do we have numbness? Do we have what we refer to as autonomic changes? Not only do I have pain, do I notice that I feel dizzy or do I feel nauseous? These are all subjective in nature. On the other side, the objective side, we're looking at more measurable and demonstrable things that have changed. Specifically, has the person lost sensation or has their reflexes become dull? Do they have weakness in their arms and their legs? Have they had a change in their ability to do what's called activities of daily living? Can they just not do day-to-day things like prepare meals or do the laundry? Have they had to change the way that they walk, or maybe they totally avoid walking altogether? And one of the big ones is, have they limited their range of motion? Have they stopped moving their joints to accommodate the pain? I think it's important for us to touch now on some basic anatomy and physiology. This right here is the bony structure in our low back. And this illustration to the left is the lumbar spine. This would be the front of our body, and this would be the back of our body. Each one of these is a vertebrae. And as you can see, Each vertebrae is separated from its partner above and below by something we call the intervertebral disc. In the back part of the vertebrae is the hinge in which the bones above and below articulate or move. So here on the right, this is a picture from behind, and it gives you a really good illustration of the hinges or the joints in the low back. Okay? This is where a lot of our dysfunction takes place. And if you look at the orientation here, you can see that the low back is almost extensively involved with allowing us to bend forward and backwards. So as if we tried to rotate side to side, this joint wouldn't allow us to do that. Well, that kind of makes sense, because the majority of injuries that occur at the low back almost always involve some sort of rotation, specifically bending forward and rotating. Taking it one step further, in this illustration on the left, we've superimposed the spinal cord. The back part of the vertebrae makes a big opening that extends from our head all the way down to our tailbone. And from there, the spinal cord transitions. As you can see, as it goes down, it gives off nerves. And there's 31 pairs of these nerves that exit from the base of the skull all the way going down to our tailbone. Additionally, in this picture, you can see that there are large ligaments that surround not only the spinal cord, but more importantly, the joints themselves. And as we go through and look closer at some of the dysfunctions that occur, we're going to talk specifically about how these ligaments fatigue over time and physically get bigger and cause something that we refer to as stenosis. Here to the right is superimposed some of the small intrinsic muscles that are in the spine. These are the muscles that don't get enough publicity. Specifically, this group right here called the multifidi. The multifidi's job is to keep the spine into its proper orientation. And when the multifidi gets weaker over time, we actually lose the ability to do that. So when folks do core exercises, in reality, we are trying to condition these small intrinsic muscles as opposed to the six-pack abs or all the ones that we see, you know, as far as bodybuilders or the muscles that look good when we go to the beach. From the top down, we can tell that the nerve roots, as they exit the spine, go all the way to our fingers and all the way to our toes. So it's an all-encompassing network that allows us to communicate with all of our muscle, skins, and bones. And more importantly, you can see it also on this side communicates with all of our organs. If we look a little bit closer to that spinal nerve, I put this illustration in there because it's very important, because it tells us a lot about why we perceive pain. And I don't want you to get bogged down on too much of the specifics in the name of these big words and all that type of stuff. But just follow me here when we talk about the way that the electrical cords are laid out. In this part of our spine, in the back, is where all the information from the outside world comes in. So this pathway is from the outside to the inside. All the information from the brain and the spinal cord that goes out starts here in the front and comes out this way. As you can see, the information in and the information out actually meet together to make something called a mixed spinal nerve. Now, let's specifically talk about the input and leave the output alone for a while. As the nerves that exit our organs and our muscles and our joints come inwards, they first meet at a level called the dorsal root ganglion, which is our first filter to determine the significance of some sort of input. Now, the input can be pain, it can be tension, it can be position in space, it could be numbness, it could be tingling, it can be all of these things. So as the input comes in, the first thing that happens is they all meet up here, and the brain and the spinal cord start to determine what is important. It filters in through here to meet the back part of your spine. This is really our small brain. This is where the majority of the communication takes place, and this is where the overwhelming majority of our pain is filtered out. In reality, the body spends most of its time trying to tell nerves to stay quiet. It causes what we refer to as an inhibition. So this part of our spine is constantly communicating to tell us if we have or do not have spinal pain. And for many people, this is where their dysfunction takes place. There's something called the gate control theory of pain in neurophysiology that more or less says this: if the amount of input that tells us where we are in space and tells us where our muscles are is greater than the amount of the input that tells us the level of our pain, then we're not going to perceive that pain. In other words, our motor function works as a way to control our sensory function. And that's why when people, for example, are hammering something and they hit their finger with the hammer, they try to shake their thumb. When they shake their thumb, they're stimulating that motor pathway to cut off the sensory pathway. So a lot of what happens takes place in here. And currently, this is where a lot of the medications work to treat. This is where the NSAIDs and the steroids all work to treat. Well, this is also where therapies like chiropractic manipulation and exercise therapy and all of these other modalities work to treat pain as well. As I just said, chiropractic works to treat that very important area of pain. And in our profession, we refer to the misalignment of vertebrae as something called the vertebral subluxation complex. So here, this is considered a relatively normal spine. And we looked at this before. Remember, this is the front of our body. This is the back of it. Here are the bones, the vertebrae, and there's the disc. Here's where the nerve exits. So you can see in this illustration where the nerve exits, the openings are pretty big uniformly. And back here, remember I touched on the ligaments. The ligaments look like they're stable and they're not growing and getting thicker. So we don't have any compression or stenosis taking place. On the right side, this is what we call a subluxation. This is when the vertebrae either moves out of its position or starts to put pressure on the nerve root. So in this case, the person has something called a spondylo. In other words, the vertebrae is sliding on one vertebrae above or below, which is causing it to pinch the nerve and also to cause it to pinch the disc. Compression of this nerve causes pain along the whole pathway. So what are the symptoms that we typically notice with the subluxation? Well, the classic one is pain, numbness, possibly weakness, changes in sensation of muscle, skin, and bones. And also, because we talked about that spinal nerve carrying lots of information, it can change our autonomic or visceral response. So when we're in pain, we'll often see things like blood pressure changes. The blood pressure physically goes up. Maybe the person, when they're in a lot of pain, is nauseous, so they have GI upset. They become constipated. We often see people who are in chronic pain don't have good breathing mechanics, so that to them it feels like their chest is heavy. And in some cases, especially in the lower part of the lumbar spine and the sacrum, it can change reproductive and urinary function as well. Well, what are the things that can cause that vertebral subluxation complex? In a subspecialty that I utilize and the other doctors in the office utilize, applied kinesiology, we often look at this triangle and call it the triad of health because there's three entities that can change us and cause this vertebral subluxation complex. The most common one, and it's obvious, is the structural one. If I slip and fall and land on my back, well, it makes sense. I could pinch a nerve. Well, also, if we change our chemistry, it can cause the nerve to become irritated. As my diet becomes more acidic Or if I produce a lot of inflammation in my body, that inflammation is going to sensitize or make the nerve more susceptible to perceive pain. So in many cases of people who have chronic pain, they're having an issue with their acidity or their chemistry that's propagating it. And that's why often the anti-inflammatory will help on the short term, but it seems to come back. And lastly, there's an emotional component. When we're under chronic pain, we have a tendency to have muscles shorten and get tighter. As that happens, it changes our posture, it changes our visceral function, and it changes our ability to combat or move. So this will often propagate the issue. Unfortunately, it's fair game for a person to have issues on the structural, the chemical, and the emotional side. And for folks that have chronic pain syndromes, typically these three are all involved. For folks that have an acute, it's mainly on this, but the chronic people almost always have some component on each of these sides. So let's talk a little bit about the importance of posture and its effect on our function. Most people who have pain don't have it because of trauma, unfortunately. Things have changed. Most people are not as active as they used to be, so it's hard for them to pinpoint when their pain started. Now, certainly there are those people that have a car accident or, have other trauma can say, hey, doc, my back pain started after the car accident. But unfortunately for a lot of people, they just say it kind of started and gotten progressively worse. With these individuals, the things that I typically start to look at is changes in posture, because the posture is more or less a representation of how that person has dealt with time, gravity, occupation, all of these things. So good posture, this person here, would see that the occiput or the base of the skull is level, the clavicles are level, the bottom of the ribs are level, the top of the pelvis is level, the knees are level, and the feet or the ankle are level. This is good posture. On the right here, this person has developed poor posture, and I'm not sure why, but we could say maybe this is the person that sits at a desk all the time, doesn't have proper workstation, and slumps forward. So look at his posture. The occiput tilts, the shoulder tilts, the rib cage becomes uneven, the spine curves, the pelvis changes, the knees changes, and the ankles as well. So good posture and poor posture are something that you need to always ongoingly assess. From the side, this would be considered good anatomical posture. A plumb line goes from the ear, goes through the shoulder, the elbow, the knee, and the ankle. And these are different changes in posture that we classically will see. This is the person that develops excessive curve in the upper back. That's called excessive kyphosis. This is a biggie. This is the person that sits at a computer all day and has their head sticking forward to get closer to the monitor. This is where the person actually loses the curvature in their spine. This is what we refer to as a military spine. Typically don't see this very common, but you do often find it with people who are very tall and very thin. This is the hyperkyphotic. This is the person who has weak abdominal muscles, and because of that, everything is pulled forward and they develop this big curve in their low back, which often jams up the lumbar spine. And lastly, this is the person that gets the double whammy. They become hyperkyphotic, they get too much curve in the mid-back, and hyperlordotic, too much curve in the low back. So this person may have low back pain, may have mid-back pain, may have neck pain, or all of the above. So what causes our posture to change? Sometimes it's things that are far away from the spine, specifically the foot. A lot of patients that I have that have chronic low back or sacroiliac or hip problems on one side have a pronated or flat foot on that side. In other words, the foot is excessively collapsing. And as the foot collapses, it causes an inward rotation of the knee, an inward rotation of the thigh bone, the femur, And that inward rotation causes this leg to be functionally shorter. So as you see here, the pelvis becomes skewed, and look, now we get a curve in the lumbar spine. So this person might try every remedy under the book to fix their low back problem, when in reality their problem is coming from the foot, which may be asymptomatic and not cause any issues. So this is an important slide to give you an illustration of why sometimes you need to look outside the box. What is maybe isn't. And additionally, I put this in here to show you some of the distal relationships between different parts of the body. There's a distinct relationship between the position of the mandible, your jawbone, and the position of your pelvis. And this has a lot to do with the way we walk, and we call that gait. I could go into this longer, but the take-home message is this. The TMJ is involved in so much more than just eating and breathing. It has a huge impact on everything that takes place neurologically below us. So in some folks that have unresolved complaints below the neck or even above it, one of the things that I'm going to look closer at is, do they have a TMJ problem? And this is when you would want to work with a neuromusculoskeletal dentist, because it can be a game changer for a person who has chronic pain that's not been solved or been able to be treated by anyone at any time. Okay, so let's go into 6 of the most common causes of back pain, and there's certainly more than these, but I picked these 6 out because they're pretty common. There's a little bit of overlap between the two, but I think as we go through this, you'll understand how each one is slightly separate, but is intimately tied into each other. The first one is something called a sprain or strain. And in reality, what a sprain or strain is it's an injury to a ligament, tendon, or even the fascia, where the force being applied to it exceeds the capacity of the tissue to hold the joint stationary or stable. In other words, we're taking that tissue, be it a ligament, tendon, even a muscle, and we're taking it beyond its capacity, and we are physically tearing it. So a sprain and strain is a polite way of saying we've torn something. There's different grades of sprains and strains. Grade 1 and 2, the muscle or the tendon, the ligament is still intact, and grades 3 and 4, it's pretty much not intact. So most folks are usually somewhere in the 1, 2, and 3 range. And depending on their injury, we might have sprains and strains of not only the fascia, but we also have the muscle and the ligament as well. This is something that becomes really important with the person who has bad posture. So those slides before where I showed you how the person has different changes in their posture, well, what's happening there is the bad posture is putting too much stress on certain tissues at the expense of not putting enough stress on the others. So they're not sharing their roles. So postural distortions typically cause chronic sprain and strains. Everyone's heard of disc herniation, so let's talk a little bit about it, because not every back pain has to do with the disc herniation, and certainly not every type of sciatica has to do with the herniation as well. But because they're very common, it's important to talk about them so we understand if or if not that they're contributing to your issue. So a disc herniation usually involves a damage to the outer part of the disc itself. It's called the annulus fibrosus, which is more or less a tough, almost leather-like structure that surrounds the outside part of the disc. Inside is a toothpaste-like constituent called the nucleus pulposus. And what will happen is the outer part over time will get damaged, and as it does that, it weakens like a tire. Maybe the sidewall of the tire becomes weak, so it bulges out. As it bulges out, it will put pressure on nerves. In this case, this is the spinal cord here. Okay. In some cases, this disc can herniate and it can ooze down here, or in other cases, it could break free and migrate. So depending on where the disc is bulged would contribute to our symptom pattern. But what I want you to understand is that upwards of 60% of the general population has a bulging disc that causes no problems at all. So we need to be very careful when we look at an MRI and make sure that what we're seeing on the MRI is actually causing the problem that makes the person go to their doctor in the first place. In many cases, the disc doesn't necessarily herniate or protrude. It just flat out degenerates over time. It gets thinner, it gets beat up, and it shrinks. It typically happens because it loses its hydration. It physically becomes dehydrated, and as it becomes dehydrated, its height slowly gets less. Okay? This will happen because of small traumas over and over again. This will happen again because of bad posture, or it just happens because of gravity and those types of things. So here we can see a normal disc. This again is the front of the body. This is the back of the body. Here's the joint. So here's the disc, and here are the nerves coming out. So this disc is happy. Well, this disc has degenerated over time, and as it's degenerated, the opening here, which is called the foramen, has gotten smaller. So this person is getting a change in the opening, and now we're putting pressure on the nerve itself. This scenario is much more common in the older folks than the disc herniation, and it will often happen at multiple levels. Now, the disc degeneration, I want you to understand, also almost always accompanies the degeneration of the joint itself, and we're going to touch on that here in a second. So I talked about the disc degenerating. Well, what happens when the bone degenerates? Well, we call that an osteophyte. That's forming actual new bone. And it typically happens to parts of the vertebrae that do not have good orientation anymore. In other words, again, we lose the normal curve. See, it all goes back to posture. Or the joint itself has been damaged. All joint surfaces are covered with a type of cartilage called hyaline cartilage, and it's super slippery. Inside the joint is a fluid called synovial fluid, which is like WD-40. So between the two of those, the joint has a lot of mobility, and it can withstand a lot of force. Now, when we traumatize the joint, we will often break down the cartilage that's in there. Well, if we break down the cartilage, then we change the way it moves. And as we change the way it moves, we lose the ability to pump that synovial fluid. So as we stop pumping the fluid, it becomes more degenerative. So we get caught up into this loop. And it almost always starts because there's a lack of poor motion at that vertebral level. So this is actually somebody's cervical spine. Their face would be here, and this is the back of their head. So as you can see, we've got lots of bone spurs right through here. And in reality, this person's spine is curved the wrong way. It should be curved this way like a C, but this guy or this lady is almost going into an S. So the changes in posture, like I said, are causing this to accelerate. If we get enough degenerative change to the vertebrae, and specifically the joints of the vertebrae, we run the risk of making it less stable. And when it becomes less stable, it will often physically shift. It can shift forward, it can shift backwards. We call that a spondylolisthesis. It almost typically happens because of degenerative changes, but it can happen if we have trauma and we break part of the spine, and it can also be congenital. Some people are born a little bit differently. There's the joints in the back part of their spine are not uniform. So as you can see in this person, okay, the upper part of the spine is all in good alignment, but what's happening is this vertebrae, so that's L5, L4 is sliding forward. Well, as it slides forward, look what it's doing. It's pressuring the disc, it's pressuring the nerve, and it's pressuring the joint. So all three of these things are pain generators. The interesting thing is Spondylolisthesis is not that uncommon, and it might be an incidental finding. So just because we see this orientation does not necessarily mean that it's actually causing any issues. As long as it's stable and it's not putting excessive pressure on the nerve, the idea isn't to send this vertebrae back, is just to get better movement through here. The one true way to test this would be with x-rays. You'd have the person bend forward and the person bend backwards to see if this distance changes. And I actually think that that's important to do with a lot of people who have chronic low back pain who don't have spondylolisthesis, because in some cases the spine might have good orientation when the person is standing, and you might not see the shift in the vertebrae till they move. So I think it's a good thing to check with people who have chronic pain, is to actually see what their spine looks like when they bend forward and backwards. Well, when we get lots of degenerative changes, or we get thickening of ligaments, remember I touched on before when we looked at the anatomy, the ligaments that surround everything, if they get thicker over time because they're under so much of a load, and let's say we also have some bulging of a disc, we're taking up a lot of room where that spinal cord is and where that nerve root is. So we see a physical reduction in the size of the spinal canal or the neural foramen, where the nerve root comes out. And the problem with this is, as we progressively choke the nerve, okay, we see it through here, we're going to almost always see progressive symptoms moving forward. Very often, this person doesn't have a lot of pain. Their complaint usually is weakness, or I feel unstable. I'm not stable on my foot. Now, I'm not saying they don't get back pain and they don't get sciatica, but for many of these folks, it's they just are getting progressively weaker. The telltale sign that you'll see with them is when they try to get out of a chair because their quadriceps and their hamstring are not strong anymore, they'll actually push themselves up with their hands. So they almost walk themselves up across their thighs by pushing with their hands. So stenosis is something that becomes pretty significant. Fortunately, we see this more commonly with older folks than younger folks, so ideally this would be caught early on and treated. But unfortunately, in some cases, because a lot of people are hesitant to go to their doctor, we know this, we don't catch the stenosis till it's far progressed. This last slide I put in because I think it's an underappreciated part of the low back itself. So our lumbar spine is here, and it sits on top of a big bone called our sacrum, okay? The sacrum sits between two hip bones, and we make something called the sacroiliac joint right here. And as you can see, there's a huge confluence of ligaments that surround it, and more importantly, we see that there's ligaments that go from the fifth lumbar and the fourth lumbar actually attached to the hip bones themselves. I like this picture because I see many people who are diagnosed with lumbar arthritis or disc bulging in the lumbar spine that truly have a sacroiliac issue that just mimics the low back pain. So this is specifically common with folks that have tremendous flexibility. As we become excessively flexible as we age, we're going to see the ligaments having to bear more and more of our weight, because as we age, we lose muscle mass. So as these ligaments bear more and more weight, and they're already loose to begin with, now we have an instability issue. And this is the person that will often get chronic low back pain. And regardless how much they treat their lumbar spine, it doesn't seem to get better. So SI joint dysfunction is a big component of why people get a lot of their low back pain. And additionally, as you might have heard when I was on the radio with Dr. Roselle, that piriformis muscle sits right in here, and underneath of it is that sciatic nerve. So if we have instability in the SI joint or the hip bones, then we get instability of the muscle that sits on top of the sciatic nerve. So becomes really important thing to look at. Okay, so where do we go from here? I think there's several things that need to take place as a clinician to get value out of the encounter with a patient. Firstly, you need to take the time to talk to the patient and review the history of the problem. When did it start? What makes it better? What makes it worse? Is there a family history of it? Take time to sift through all the details. Secondly, the inspecting part of the body becomes extremely important. If you do not do a proper physical exam, orthopedic test, and neurological test, you're not going to have a comprehensive understanding of the dysfunction that the person has. Meaning that when I go on to confirm my diagnosis, I'm going to have confusion because I did not do the physical exam. So the confirming of the diagnosis to me would be, I've done a good history, I've done a good physical exam, I'm 85% sure that I know what's causing it. So to confirm it, this is when our MRIs come in, our X-rays come in, laboratory testing to give me confirmation on whatever I thought was happening is happening. And now, because I have a working diagnosis, I can come up with a treatment plan, okay? And any treatment plan is only as good as what it changes. So you need to do follow-up of your testing. So if the person on their initial encounter had limited in range of motion and changes in strength and all these objective measures, then you want to follow up on that to see that they improve. It's one thing if a person feels better. It's another thing if they feel better and they're more stable. And that's our goal. We want the person to be stable. Stability is a good thing. Once they become stable, though, you often have to help them develop a maintenance plan. Give them the understanding of the things that they need to do to keep all of these things into place and make sure we don't backslip. So here are the steps that we do when we go through this whole process. So the first part of the clinical assessment of the injured person or the chronically injured person is what's called PART. That's the actual physical exam. We're going to palpate the area. That's going to touch the area. We're going to see if there's asymmetry. Is the left leg smaller than the right leg? What's the range of motion at the right hip compared to the left hip? And T stands for the texture or the temperature of the skin. Is there heat over the area? That's an indication that we have inflammation. At this point, we want to progress into doing some orthopedic and neurological testing. That again expands on our working diagnosis. I touched a lot on posture and gait, so we're going to stand the person up. We're going to look at their posture. We're going to watch them walk. This can either be an indication of how they have adapted to their problem, or it can be an indication of what caused their problem. Doesn't matter. We want good posture and we want good gait. In my profession, chiropractic, we look closely at the spine and specifically how well the spine moves. So we're going to look at each of the segments in the spine to make sure that we have good motion. And that includes areas above and below the lumbar area, the low back area. Again, sometimes the problem is outside the box. The next thing that we'll consider is something called applied kinesiology. And this is a technique that we utilize ongoingly in our office that looks at muscle function testing as a representation of what the nervous system is thinking. So we're going to check different muscles to make sure that they're competent, they have good strength. We want to make sure that we have balance front to back and side to side. In some cases, we might even dig deeper into what the person is doing as far as what they eat and they drink. Pain, for the most part, is an inflammatory event. So if our diet is inflammatory or acidic in nature, we can propagate the pain cycle. So for some folks, we're going to look closer at that. And the biggies are the white things, so white flour, sugars, rice, potatoes, pasta, all the tasty things have a tendency to cause us to be acidic and change the inflammatory cascade. So what is the person eating? As I touched on before, we're going to probably order some films, an MRI, maybe a CT. And in some cases, the problem may be metabolic that mimics a musculoskeletal. So maybe we'll do some laboratory testing. What if it's an autoimmune problem that's just mimicking just old-fashioned arthritis? Well, You need to ferret that out by doing laboratory analysis. I added this slide about applied kinesiology because I think it's important you understand this aspect of what we do in the office. You've seen this picture, remember, the triad of health I talked about before. This is the structure, the mental, and the chemical things that affect us. Here's a person in the background. There's a plumb line that goes straight through his body, so he's got good posture, good integrity. So the things that ultimately affect this person's health is his neurological system, his lymphatic or trash removal system, his vascular supply, the blood supply, the WD-40 around all those nerves, the lubricant, we call it cerebrospinal fluid, and also the inherent energy network in the body called the acupuncture meridian connector. So yes, applied kinesiology looks closely at the invisible network called acupuncture. So this is the way we currently see people treated for chronic pain syndromes. It can be back pain, shoulder pain, it doesn't really matter. We're treating the symptom and not the problem. The biggies right here, anti-inflammatories. Okay, that can be prescription or over the counter. What the problem is there with chronic use, we cause GI bleeding. As a matter of fact, the most common cause of an undiagnosed bleeding ulcer is chronic NSAID use. So taking those things over and over again will cause the gastrointestinal tract to be damaged, and eventually, as we beat up the mucous membrane lining, it'll start to bleed. They can put excessive load on the liver and cause damage there. It could probably also put the kidneys in there. And this one is really, really important as well. The mechanism of action of the anti-inflammatories also blocks the absorption of what we call a sulfate ions. Sulfur is inherently involved in all of our connective tissue. So when we take anti-inflammatories, we block the uptake of sulfur into our joints. So in fact, when we're taking these NSAIDs for, let's say, a bad knee, we're actually damaging the other joints in our body by starving it of sulfur. Now, we've all heard of people taking glucosamine sulfate and chondroitin sulfate, MSM. Those are all sulfur donors. So that's why those help, because we need sulfur. Well, if you're taking anti-inflammatory on one side and taking your glucosamine on the other, you're at best breaking it even, and at worst, you're just on a downward trajectory. So anti-inflammatories for long terms, that's a big no-no. The next common one that I see, muscle relaxers, also, painkillers. We could, slash, one or the other. The problem is there's a dependency, impaired cognition. You don't have to, be a physician to know that we got into a big trouble with all the OxyContin and other prescription drugs that were being prescribed. So it's not the way to treat these types of problems. At best, it's a stopgap for a few days, but when you put people on these chronically, and we call that pain management, it's very tough for them to come off of it. A couple other things that I put in here, bracing. It used to be very common that we would see people wear a low back brace or, an ankle brace after they get a tendonitis. Well, the problem with the bracing is it causes weaknesses of the muscles that are involved. So it perpetuates the issue. Same for bed rest. We just don't see people rest their back like they used to. In the 70s, if you threw out your back, the prescription was to, bed rest. Well, we now know that was not a good idea because it causes atrophy throughout the whole body. So, how do we treat this on a more conservative basis that's actually going to change structure and is going to improve integrity of the system? First, if the joint isn't moving, we got to get it to move. Classically, chiropractic, osteopathic do what we refer to as spinal manipulations. They correct those spinal vertebral subluxations. In some cases, they might even work on the craniosacral system and the TMJ. Hands-on, we would also look at muscle function and the fascia. If we have restriction in the fascia and the muscle, there's ways that we can free that up as well. So Again, if we've lost motion in a joint, that is paramount to fix before everything else. We've got to get good motion to have good function. So once we get good functionality in the joint, it's time to do some rehabilitation. So there's stretches and strengthening that are very beneficial for almost every injury that's out there. In many cases, we need to educate the person on proper ergonomics, that's proper ways to sit and to sleep and to work, to change their posture. Again, many people, their issue is a postural issue. And if they don't change it, they're going to continue to put strain on the sensitive tissues. If a person has a very poor diet or is exposed to a lot of toxic substances, it's going to eventually put a strain on the liver and the GI tract. So in some cases, if a person specifically, I find this more so true with people who have global pain, that if you do a detoxification with them, a combination of changing diet, improving gut function, and then pulling toxic materials out of the body, their outcomes become much, much better, and their symptom patterns become much quicker. So again, for some people, this is the icing on the cake. Once they do the detoxification and they clean the diet up, that last little lingering bit of their aches and pains go away. There's passive modalities that bring extreme value in the healing process, and these can either involve lasers, electrical currents, or sound waves. All of these work on reducing inflammation, increasing blood flow, and promoting tissue healing. So if the joint has been traumatized and it's inflamed, we have arthritis in the joint, we have thickening of the ligaments and those types of things, we want to do some therapies to promote that tissue to strengthen and to regenerate. So these modalities are super valuable in the process. And again, I put a little bit here at the bottom on dieting. There's ways of doing acid and alkaline balancing. For some people, it's a blood sugar control issue, or they're eating too much trans fats or artificial sweeteners and chemicals, which are what we refer to as neurotoxins. And for some people, they just don't drink enough water. All of the connective tissue in the body is composed of about 65% water. So if you're dehydrated, you're going to pull it from the connective tissue, and it's going to change you. It's going to make you stiff. It's going to make you achy, and it's going to perpetuate your problem. Now, once we get the person to a place of wellness and they're feeling good, then human nature says, out of pain, out of problem. And this is the danger zone for a lot of people. So I often will talk to folks about different forms of wellness care, and I call it the 4 R's. So ongoingly, we should assess, are they reforming these subluxations? In other words, do the vertebrae stop moving? Is their diet slipping back to what it used to be? Are they going back to their bad habits? Is their posture becoming bad again because now all of a sudden their back doesn't hurt so they can slump? Okay? Does the person need to replace things in their body? Nutrients, hydration, and what about mindset? There's a lot of people that just assume that because they're older, they should have back pain, and that's absolutely not the truth. So some folks, we need to replace their mindset. Their brain is not in a good place. Ongoingly, we should have a rehabilitative program in place. We would do things to improve muscle strength. We want good joint function, and we want proper form and gait. Again, gait and posture is more or less a representation of the way that you're dealing with your body at that time. And ultimately, we want to review things. Moving forward, the person's number one goal might have been their low back pain. Well, what else do they want to achieve? Do they have health goals? Do they want to go back to playing tennis? How can they plan for the future to stay engaged? So in closing, we went over quite a bit of information, and I encourage anyone who's a patient in the office to grab me in the hallway if you have any questions. And for those of you who are not patients in the office, if you have any questions, you can certainly call us at 703-698-7117 Or you can email me at h.browning@Roselle Care, and I'd be more than happy to answer any of your questions. The next slide is going to talk about an opportunity for those folks to come into the office who really need to get looked at. These are for people who have already tried everything under the sun and are still not getting the results. So, please feel free to take advantage of this offer. It's a full evaluation in the office with me. We'll look at what you've done. We'll probably go through your laboratory testing and your imaging and see if we can come up with a better option. I thank you so much for listening in tonight, and I will be back, I believe, in 2 months to go over more material. Thank you.